Hello, my name is Dr. Dolores Pretorius, and I'm a professor of radiology at the University of California, San Diego. I'm going to talk to you about congenital anomalies, the basics, part one, and then a separate talk for part two. This is an unknown case. Just to get you started, we're looking at the fetal head. So this is the nuchal area with the posterior fossa right here, the cavum and the frontal horns here. And this is a cystic hygroma, which is because of this thickening and septations in the neck region. I'd like to go through first oligohydramnios, and then we'll go through polyhydramnios. So the causes of oligo are demise. I like this little mnemonic, DRIPSy. Demise is obvious. R, renal. I for intrauterine growth restriction or placental insufficiency. P, post-dates, which you usually know. And P, premature rupture of membranes. And C, chromosomes. Let's first look at some of the renal diseases from urinary tract dilation. We think about urinary ureteropelvic junction obstruction. We think about posterurethral valves. We think about reflux. We think about duplicated kidneys. And we think about renal cystic diseases that may not function. And we think about renal agenesis. The guidelines from 2014 from the Fetal Urologic Society talk to us about the measurements that we can use for low risk versus high risk. We use the number 4 up until 28 weeks, and then the number 7 after 28 weeks. And for severe, we use 7 at 28 weeks and 10 after 28 weeks. And we look for calyceal dilatation and the parenchyma and whether it's abnormal. We look at the ureters, the bladder, and for other causes of oligo. Now, greater than 4 millimeters till 24 weeks, 7 at 28, and we check for that caliectasis in a longitudinal scan. We look at the bladder to try to find ureteroceles or posturethral valves. We check for duplicated kidney, and then we recommend a follow-up at 32 weeks. This was a patient that came in and just had minimal dilation, 4.1. At her anatomy scan at 22 weeks, and on her longitudinal, just had a tiny bit of calyceal dilation in the upper and lower poles. But when and what we would normally do with her at 22 weeks is talk to her, and we do this every day. We would draw pictures of the kidneys, the ureters, and the bladder, and we would say that this may very likely be normal from just immaturity of the nerves to move the urine down into the pelvis. Or it could be an obstruction high in the ureter, likely a UPJ, or narrowing low in the ureter from a UVJ, or reflux going back up. And we do that follow-up at 32 weeks, and we tell them that we're trying to prevent urinary tract infections that can lead to sepsis in the early neonatal period that can make the baby very sick. And in fact, in San Diego, at our children's hospital, they tell us that we get about 1 case a week of a urinary tract infection leading to sepsis in a newborn. So this patient came back at 35 weeks, and you can see that the pelvis has grown now from 4 to almost 13 millimeters. There's dilation of the calyces, and on this longitudinal, you can see marked hydronephrosis. And when we looked at the bladder, we didn't see any ureterocele. In contrast to this patient that had dilation of 7, and when you looked longitudinal, you saw upper pole dilation with just a little bit of lower pole dilation, a very large dilated ureter. And when you looked at the other kidney, you saw upper pole dilation with lower pole looking good, a little bit smaller ureter. And then when you went down to look at the bladder, you could see the ureterocele right here, where there's a little balloon inside the bladder. We always say that the upper pole obstructs, and those are both vowels, U and O, and the lower pole reflexes, L and R, both consonants. Okay, if you think about polyhydramnios, we think about idiopathic causes, whereas most oligo has a reason. Poly may not. 20% will be maternal problems from diabetes and isoimmunization, and 20% will be related to fetal anomalies. So when we think about fetal anomalies, I always start at the head and go down. A central nervous system, cleft lip and palate, lung problems, cardiac problems, gastrointestinal problems, skeletal dysplasias, and then chromosomal anomalies in twins. So if you think about the CNS problems in the head that can lead to polyhydramnios, we think about anencephaly, ventriculomegaly, holoprosencephaly, Dandy-Walker malformation, encephalocele, meningomyelocele, and agenesis of the corpus callosum. Anencephaly occurs about 1 per 1,000 births. There's an increased recurrence if you've had one neural tube defect, that you can have another on a subsequent pregnancy, which may not be the same neural tube defect. It might be a Chiari the second time, the third time might be encephalocele. But anencephaly is absence of the cranial vault and the brain tissue, and it occurs at about 2 to 3 weeks of gestational age. And these can present as early as the first trimester with a short crown rumpling. The other findings are that you will see this kind of frog-eyed picture of the 2 orbits here with the nose in between and no cranium on top. And if you look at a sagittal picture, you see the cervical spine with the base of the cranium and really nothing on top. And here's a cine showing you that cervical spine with the base of the brain, nothing on top. And when you turn 90 degrees, you see the frog eyes here coming out and the nose there, because they will have a normal face. Okay, moving on to holoprosencephaly. This is maldevelopment of the forebrain. You can be alobar, a most severe type, semi-lobar, an intermediate type, or lobar, the least severe type. They often have facial anomalies like a proboscis, cleft lip and palate, hypotelorism, and even on to cyclops, and they can be associated with trisomy 13. We look for the monoventricle of holoprosencephaly, fused thalami, no falx, an absent cavum, septipellucidity, facial anomalies that we just discussed, and then any other findings associated with trisomy 13 like polydactyly and cystic kidneys. Here we have the monoventricle and the fused thalami. We have a dorsal cyst that sits behind the monoventricle, and you can see it in this coronal plane as well. And then here we have hypotelorism, where you do not see the orbit in between the two. And this fetus also has a single nostril, which goes along with holoprosencephaly of midline facial defects. Not only those abnormalities go with trisomy 13, but I already mentioned that you can have these cystic kidneys that can look large and echogenic like there or like here. Sometimes you'll see the cysts, sometimes you won't. Here's the polydactyly with the thumb and 5 digits. And they can also have congenital heart disease like most chromosomal abnormalities. Here is the proboscis that you can see on this frontal view of this 3D volume. And when you look on the axial view, you see the hypotelorism with these small little orbits, and that's what it looked like on the rendered view. And there's the proboscis on that rendered view, and that's what it looked like after birth. Mild ventriculomegaly is generally thought of as 10 to 12 millimeters. Sometimes people will lump it into the 10 to 15. They can have associated abnormalities, chromosomal abnormalities, but many will be isolated and do well in the neonatal period. Now here's a case with dilated ventricles at the anatomy scan of 10 to 12. This one was 10 to 11, just barely dilated. Most of these will turn out to be normal, but some of them won't. This one has dangling choroid that you can see right here. This one looks a little more shrunken. And when she came back, she'd had marked progression of her ventriculomegaly with dilated atrium, dilated frontal horns, and this was up to 28 millimeters. Now, if you look at a very large series of meta-analysis of 2,100 citations, 3% ended up with an abnormal karyotype, 4% an abnormal neurological abnormality, and 0.4% had an infection like CMV. We take these patients and offer them MRI if we see it before 24 weeks. And even after 24 weeks, but we usually want to see that it didn't go on and progress. This patient had a 10 millimeter and a flattened lemon sign to the parietal bones, and this was a Chiari malformation. Dandy Walker malformation distorts the tentorium and enlarges it, moves it up. And you can see it nicely on this MRI as well, the Dandy Walker with mild ventriculomegaly. We found ventriculomegaly in about 50% of Dandy Walker malformations. Now, we used to think that Dandy Walker always had an absence of the vermis, but that's not true today. We know that it can have a residual part of a small part of a vermis. It's the most important part is that tent is being elevated. Now, there are other causes of dilated cisterna magna besides Dandy Walker. It can be normal up until 18 weeks of gestation and have a normal keyhole appearance. It can be related to the vermis, vermian hypoplasia, so you can measure the superior to inferior vermis and put it on tables and see if it's too small. It can be to a megacisterna magna or a Blake's pouch cyst where the vermis rotates. It can be to cerebellar hypoplasia, so you may want to measure that from side to side. It can be related to Gilbert's syndrome, where you see that molar tooth sign. And it can be you can find both MRI and 3D ultrasound helpful for this. Here's a picture using some figures from Robinson, where the vermis is normal here, and this is the normal physiologic Blake's pouch cyst, which will fenestrate and become the foramen agendi right here. And here's an MRI showing the midbrain right there and the vermis. And then on the ultrasound, you can see the vermis right here with the little fourth ventricle, and the midbrain would be right there. This fetus has been rotated to be sitting straight up like routine MRs. Here's a Blake's pouch cyst that pulls it out and rotates that vermis, and there's the fourth ventricle. And here you can see this is rotated out on this MRI with this cisterna magna. And then here's another on ultrasound with there's the vermis being pulled out, and here's the Blake's pouch. A megacisterna magna is when the vermis stays in line adjacent to the midbrain and still has this large cisterna magna. So you can see that here. This is right next to the midbrain, and this is the large cisterna magna. And here it is on 3D ultrasound with there's the fourth ventricle, there's the vermis lined up right adjacent to the midbrain, and there's the large cisterna magna. I'd also just like to mention agenesis of the corpus callosum, because they can have dilated ventricles that are sort of in appearance of a teardrop, this colpocephaly with the dilation of the atrium, and you can see that also on this MR right here, that's teardrop. They give absence of the cavum in the midline, but they may have a pseudocavum that can kind of simulate it, and it's often related to fluid in between the hemispheres. They can have radiating sulci on the sagittal view and absence of the pericallosal artery. Now, here's a case with agenesis of the corpus callosum, just to remind you that earlier on, these findings may not be as visible. So here is a ventricle that looks pretty normal, measured totally normal, even at 21 weeks when she came back, because we couldn't see the cavum. The ventricles looked totally normal in size, 6 and 7 millimeters. There was a little tiny more dilation posteriorly, but we did not call anything. And not until 30 weeks did we see the colpocephaly measuring up to 12 millimeters and that teardrop appearance to the ventricles. Here's an MRI on agenesis of the corpus callosum, and you can see that this study at 21 weeks was called a normal cavum, but it really wasn't. It was really fluid that was in the interhemispheric fissure there between the two hemispheres, and this was a pseudocavum. There was, by the time she got to 30 weeks, she did have colpocephaly, but she did not have that at her 20-week scan. So this was really just the fluid in between the hemispheres. Here is a normal cavum and normal frontal horns that sit right next to it. So I won't call normal cavum anymore unless I see those frontal horns coming down adjacent to it. Other causes of absence of the cavum septipellucidity besides agenesis of the corpus callosum include holoprosencephaly and septo-optic dysplasia. And here's a case of septo-optic dysplasia where the frontal horns are continuous and you don't see the walls of the cavum that we should see. Many neural tube defects do present with high AFP. So I'd just like to review with you the causes of high AFP. About 25% of the cases will be due to off dates because it's very dependent on the gestational age. About 5 to 10% will be due to multiple gestations making more AFP. A smaller percent, up to 7%, will actually have abnormalities like neural tube defects and ventricular wall defects like gastroschisis, which have a very high AFP, often 10 multiples of the median. And then the most common cause of high AFP is a mixing of blood between mom and baby. So that is a fetal maternal hemorrhage. So if you get any history of bleeding in the pregnancy, then that is often the cause of the high AFP. But you always want to look for placenta accreta as the cause of mixing of blood leading to a high AFP because it is a life-threatening disease for mom and they can have significant bleeding at delivery. There are many other causes of high AFP too, like Turner syndrome, GI atresias, finished nephrosis, abnormal chromosomes, cleft lip and palate with the breaking of the skin to release that protein into the amniotic fluid. Same with amniotic band syndrome, sacrococcygeal teratoma, chorioangiomas of the placenta, the most common tumor of the placenta, and then maternal causes like diabetes, hepatitis, and hepatic tumors like colon cancer. Encephaloceles are masses that are adjacent to the head. The encephalocele has brain and meninges in it, whereas the meningocele just has the meninges and CSF in it. These are often midline. They're more commonly occipital than frontal, but our Southeast Asian population has them more often frontal. And anytime you see an encephalocele, you want to think about Meckel-Gruber syndrome, which is associated with cystic renal dysplasia and polydactyly. So here's a encephalocele that you can see the mass coming off the head posteriorly and that there is brain tissue within it. And so this is a fairly large encephalocele. I'd like to next review the Chiari malformation or neural tube defects. There is widening or splaying of the posterior elements, a U-shaped configuration of the vertebral bodies, scoliosis and kyphosis, a meningeal sac, and then cranial findings. So this is a patient that has the splaying of the posterior elements. I'd like to show you first the normal T12 with there's the vertebral body centra. These are the two posterior elements. And then here is an abnormal, one low level down where the posterior elements are splayed, and there's the vertebral body centra. So those are the finding in the lower spine on a transverse. And then on a longitudinal, you might get the sac to be seen adjacent to the vertebral bodies. On the coronal, you may just see slight widening here in this region. That was at about S3-4. Now, the cranial findings of neural tube defects are very helpful in picking up this abnormality. First is the Lemon sign, which is the flattening of the parietal bones. Second is the banana sign, which is the cerebellum curving around. And then the third sign is effacement of that cisterna magna that is not there. The next sign is ventriculomegaly. And then interestingly, they tend to have a small BPD in the second trimester and only blossom out when they get ventriculomegaly. They may or may not have a significant increase in the size of their brain. So here we have that lemon sign with the flattening of the parental parietal bones. We have the ventriculomegaly with the shrunken choroid down here. And then we also have the banana sign with the cerebellum curving around like this and no cisterna magna there at all. 3% of the population will have a choroid plexus cyst, and this is a marker for trisomy 18, a soft marker. It doesn't have any specific problem in and of itself. It's just that it raises your risk for trisomy 18. And we use 3 millimeters as our cutoff. If it's above 3, we call it a choroid plexus cyst. If it's under 3, we call it heterogeneity in the choroid. And we don't talk to patients about that. It does, whenever you find it, we look at the integrated sequential screen and or the quad marker, whatever the patient has. And some patients today will already have NIPT, non-invasive prenatal testing, also called free cell DNA, to give us a risk of what their risk is for trisomy 21 and trisomy 18. But we always look for other findings of trisomy 18 as soon as we see a choroid plexus cyst, like clenched hands, which are supposed to be present in about 95% of patients, club foot or rocker bottom foot, heart disease, or phalloceles. And this is a patient that has a small little I think it's 5 millimeter choroid plexus cyst in this patient. And we see this every other day in our practice. These patients get clenched hands with the index finger overriding the other digits. And this is just a 3D picture with that finger overriding. And that's what it looks like on autopsy here with that index finger overriding. Now, in order to call a normal hand, we want to see at least 3 digits with the 3 phalanges on it to prove that that hand is open. We won't accept a sagittal picture of the hand because we've been burned on that. Okay, here's another unknown case for you to just take a break and look at. So do you think this is placenta accreta? Do you think it's vasoprevia, marginal cord insertion, or filamentous cord insertion? And the answer is vasoprevia. So this is a filamentous cord that goes in and tracks over the cervix and goes back to the placenta. This is a vasoprevia from a filamentous cord. Now, the Society of Maternal-Fetal Medicine has guidelines for vasoprevia. They occur about 1 per 2,500 deliveries. And they're either from a case like this one, a filamentous cord covering the cervix, or from a suction chariot lobe with 2 parts of the placenta and a fetal vessel crossing between them that goes over the cervix or within 2 centimeters of the cervix. If that membrane should rupture, like when you rupture membranes and you go into labor, then you have a 43% chance of, 43% will make it and about 50% won't because of fetal death and asphyxia from bleeding out. If you make the diagnosis with ultrasound, then you have about a 98% survival. You do tend to need transvaginal to be able to confirm it after you suspect it on a transabdominal. And sometimes you actually have to move the head out of the pelvis with your hands in order to get fluid between the head and the cervix to see whether there's a cord down there. And color Doppler is extremely helpful. It can be done with grayscale, but much easier with color. We treat these babies with corticosteroids between 28 and 32 weeks. We hospitalize them between 30 and 34 and deliver them between 34 and 37. In San Diego, we deliver them all at 34 weeks. And about 28% will end up with an emergent preterm delivery. So that is the end of part 1.